Good day, welcome everyone. Thank you for joining. We're going to give other colleagues just one more minute and then we'll start. Good day everyone, thank you for joining. While we wait for other colleagues to start, just wanted to let you know that you will receive the slides that we present to you, along with a policy brief that will accompany it. So you'll receive that in the next few days. Please can you use the Q&A function to record any questions that you have. This will ensure that the panelists see those questions and can respond in a timely fashion. We have a wonderful group of people here today on this webinar from diverse backgrounds and who've been playing different roles throughout the COVID-19 response. So we'd really love to hear from you. So please use the Q&A and please do comment throughout. The COVID-19 vaccine survey is funded by the Bill and Melinda Gates Foundation and is conducted by the Southern Africa Labour and Development Research Unit at the University of Cape Town. I am currently having a personal experience with COVID. I've been sick for the past 3 weeks and struggling to recover. My experience has made me extremely grateful for the protection that I've got through my vaccination, and our team is really passionate about helping to extend that coverage to as many people as we can. So we really appreciate you joining us and sharing your time today, and we hope that our survey will inform the work that you do. In this webinar, we will first present a summary of the key findings, and then followed by a description of the CVACS survey and aims. We'll then have a presentation of the results from the surveys, followed by a panelist discussion. We are very fortunate to have 3 individuals join us on the panel who have been central to the COVID-19 response: David Harrison, Gugu Ngubane, and Mosima Mabunda. So we look forward to hearing their reflections on the CVACS findings. This will be followed by a brief Q&A session. So starting with an overview of the key findings and implications, the survey provides insights from both a sample of individuals who got vaccinated between the 2 CVACS surveys and a sample of unvaccinated individuals. Here we see the key findings and implications from the vaccinated respondents. Findings show that vaccinated people themselves are likely our best ambassadors. They were very happy with their decision to get vaccinated. They recommended the vaccine to others, and they can provide social proof that the vaccine is safe. When looking at the reasons people gave for why they got vaccinated, overwhelmingly the most common reason was mandates, with work mandates being the most common, followed by other types of mandates, like mandates for university attendance. This and other findings that you'll see through the presentation all point towards mandates likely being the most effective strategy we have left in the toolkit. The survey for CVACS happened after the 4th wave of COVID-19 infections in South Africa. We see that many people got vaccinated because they saw the high number of COVID cases and related negative health impacts of COVID during that time. So as we move to a fifth wave, it might help encourage or nudge some individuals to vaccinate if we make those risks salient without creating fear. Then we found that the actions of others getting vaccinated influence people in two ways. First, they saw other people getting vaccinated. They didn't want to be left out, and they saw that it was a social norm, and that is why they got vaccinated. The other action is that when they saw people getting vaccinated, they learned that the vaccine is actually safe and overcame some of their fears around safety. Both of these point to the potential programming using social norms, as well as increasing awareness that vaccinated people remain healthy. Looking at the unvaccinated respondents now, one of the key findings from the survey is that most of the unvaccinated individuals do not plan to get vaccinated. Most say they'll get vaccinated only if required, or definitely not. This represents a really big shift from Survey 1 in November and December, where the majority were more on the least hesitant side, rather than now where they're on the most hesitant side. This indicates that longer term and more intensive strategies are likely needed going forward among the hesitant, with quick win demand creation strategies less likely to be impactful. We also see that hesitancy is most common among the privileged, suggesting that increasing vaccine access and messaging are unlikely to work in better resourced areas. Of concern, we see that individuals who are vulnerable to the negative health impacts of COVID, people living with chronic illnesses, were not more likely to want to get vaccinated than people who didn't have chronic illnesses. This indicates that we may need tailored campaigns among such high-risk populations. These campaigns and messaging will likely need to go through channels other than the government, as we now see in the unvaccinated sample widespread mistrust of the COVID-19 information from government. Three very widely held beliefs among the unvaccinated all point in the opposite direction to people wanting to get vaccinated. Most believe that they do not need a vaccine. Very few think the vaccine works. And the majority believe that the vaccine is more likely to harm people than to keep them healthy. Hesitancy will remain really deep-seated while people have fears around safety to this degree, and it's going to be really difficult to convince this group to get vaccinated. Linked to the fears around safety, when looking at the reasons why people gave for not having been vaccinated, we see that many people believed that their current physical state, either being ill, having a chronic illness, or breastfeeding or being pregnant, precluded them from getting vaccinated because of safety concerns. So it's going to be really important to create awareness of the vaccine safety among these groups. As we work hard to do that, we still need to make sure that there's easy access to vaccinations. Access constraints still remain for many individuals, so we want individuals to be able to get vaccinated when they want to. The results from both the vaccinated and the unvaccinated sample point towards mandates being the most effective strategy that remains. However, despite most believing that the vaccine will be effective in increasing, that the mandates will be effective in increasing vaccinations, most oppose them. And the opposition is based on individual rights mainly. So strategies based around mandates and requirements will need to be designed with sensitivity to the likely opposition. Careful framing will be required, and the government's role may be to support and facilitate NGOs and private institutions' mandates and requirements while maintaining government mandates where feasible and effective. I will go through the next slides very quickly. As I've said, you will receive the slide deck and a policy brief, and all that information will be in there. So CVACS aimed to provide information on factors influencing vaccine uptake, including hesitancy and demand side constraints and access barriers. The overall aim was to provide information which could inform the development of vaccine promotion strategies. All data were collected using telephone surveys, and a crowdsourcing platform and process was used to create the questions for each of the surveys. Many of you in this webinar contributed to that, to the crowdsourcing of questions, and we are really grateful for your contribution. This process helped to ensure that the information we collected was or is both relevant to and informed by the experience of people working on different aspects of the COVID-19 response. Key to notes in this timeline is the icon with the cloud, which shows when the CVACS data is and was released. So we see that the first survey's data was released in early March, and that is publicly available to you. And our team will put the link in the chat to where you can find the data. And we will release the data from survey 2 at the end of this month. Our CVACS team was supported by many colleagues at Soldru, including Kelly Ardington, Nicola Branson, Murray Labrand, Vilma Ranchard, and Reza Daniels. And we are grateful for their contribution. And the CVACS team consisted of colleagues from both the University of Cape Town and from the University of Pennsylvania. We had a really fantastic team that ensured the high quality data and the accurate coding of our data. And we're really grateful for our consultative group who were central to the design of the CVACS survey in the beginning, as well as the development of the questionnaire and facilitating the crowdsourcing platform, and the sharing of results and policy engagement. So thank you for your critical contributions. The CVACS sample was drawn from a credit bureau database that was overlaid with enumeration area, level, and census 2011 information. The sample was stratified on a range of characteristics, with the age categories based on the categories used for the national vaccine rollout. Of note, we have used survey weights to adjust the findings that you will see in this presentation. Design weights were used to adjust for the survey design and for non-response for the cross-sectional analysis of the Wave 2 survey data, and panel weights were used to adjust for attrition and used for any analysis using both the survey 1 and the survey 2 data. It's really important to keep in mind that CVACS is not a prevalence survey, so results are not nationally representative. So this is what the survey looked like. In survey 1 in November and December 2021, we surveyed a sample of individuals who self-reported that they were unvaccinated, 3,510 individuals. In survey 2, we attempted to re-interview as many of these individuals as possible. We re-interviewed 386 individuals who told us they were vaccinated, and we re-interviewed 1,386 individuals who told us that they were still unvaccinated. So our survey 2 sample of unvaccinated individuals consists of the individuals that were re-interviewed in survey 2, as well as a new top-up sample of unvaccinated individuals who increased our sample size to the total of 3,608. It's worth noting that the number of individuals that we re-interviewed is quite small, but we still learn a lot of really important insights from this group, especially from the vaccinated individuals. What you see here is in gray the average daily new confirmed cases of COVID in South Africa. The blue shows the cumulative COVID-19 vaccines administered, and the 2 orange show the survey period 1 and survey 2. The survey 2 was conducted from the 23rd of February to the 25th of March 2022. It's worth bearing in mind that a huge number of demand creation activities happened between the 2 surveys. There was the Boomer Voucher vaccination incentive program, which started in November. There was the vaccination lucky draws, increasing access to vaccination over weekends, many initiatives to increase access and provide transport support, and among other things, a large number of TV and national radio campaigns. So a lot happened during the two surveys, including the peak of the 4th wave of COVID infections. So we now turn to look specifically at the 386 vaccinated respondents. These individuals reported having received at least 1 dose of a vaccine, which means that not all these respondents may have been fully vaccinated. Vaccinated respondents came from all provinces, with the most from Gauteng, with 107. Half the respondents lived in township or in informal areas. Having a look at the rates of vaccination between the CVACS surveys 1 and 2, out of all the respondents who were surveyed in both CVACS survey 1 and CVACS survey 2, we found a vaccination rate of 19% between December and March among those CVACS respondents who were unvaccinated in the first survey. This vaccination rate is much higher than the national average. Nationally, among individuals who were unvaccinated as of mid-December 2021, the vaccination rate was approximately 7.5% during the same period. The big difference here is likely driven by selection bias in the CVACS sample, consisting of both sampling bias and also CVACS survey attrition. We see that our sample was equally split by gender. The vaccinated sample comprised 53% of them were 18 to 34-year-olds, so skewed towards the younger end of the spectrum, and 55% had completed grade 12. This slide shows factors that were measured in Survey 1 that had an influence on individuals getting vaccinated between the surveys. The chart on the left shows responses to questions we asked around individuals' plans and intentions about vaccination. So in both surveys, we asked individuals regarding the COVID-19 vaccine, do you intend to get it as soon as possible, wait and see, get it only if required, or definitely not get it? What we see in the chart is the vaccination intentions that people reported in Survey 1 among those who ended up reporting being vaccinated by Survey 2. So what we see is that there's a very strong relationship between intentions and getting vaccinated, which one would expect, with 64% of those who got vaccinated having said they want to get vaccinated as soon as possible. I think what's really interesting and important about this figure is the fact that almost 1 in 5 individuals were vaccinated despite having previously expressed high levels of vaccine hesitancy. So 6% had said definitely not in Survey 1, 12% had said only if required, and that percentage were vaccinated going forward. I think what this speaks to is the potential for intentions to shift, or the potential for people to get vaccinated despite not wanting to, as would be the case of mandates. The figure on the right shows results from multivariable regression analyses that controlled for various demographic and socioeconomic factors, looking at the factors measured in Survey 1 that predicted the vaccination by Survey 2. What we see is that individuals who in Survey 1 had lived with or were living with an individual in the household who was vaccinated had about a 36% increase in the odds of getting vaccinated. Those in Survey 1 who believed that the vaccine may kill them had a decrease odds of getting vaccinated of about 25%. And strikingly, in Survey 1, individuals who believed that the vaccine works, it would help prevent them from dying, had an increased odds of around 135% of getting vaccinated. So why did people get vaccinated? We asked a series of open-ended questions during our survey. And with each of these questions, we did a thematic coding of the responses. And in all figures like this that you see through the presentation, we show the top 10 most common reasons, with the larger text indicating that the reason was more common. So we asked vaccinated respondents, what is the main reason you decided to get vaccinated? Overwhelmingly, the most common was to protect myself from COVID, with notably far fewer saying to protect those around me. The other reasons that you see on the slide will be reflected in the following question that we asked, which was, what is the main thing that changed or helped you decide to get vaccinated? Overwhelmingly, the most common reason that people got vaccinated was because of mandates, with 1 in 5 mentioning employment-related mandates, and 1 in 10 mentioning mandates of other kinds. People got vaccinated both because they were looking for jobs and thought that it was a requirement for job applications, and because they were in a job and wanted to keep their job. Other reasons that people got vaccinated included seeing or becoming aware of many other people getting vaccinated, speaking to the social norms, witnessing or becoming aware of COVID sickness or death, so the risks becoming more salient. And at the bottom of the screen, the health systems change, the health status change. So what we see there is that many people had previously believed that because they had a chronic illness or because they were pregnant or breastfeeding, they could not get vaccinated. And then they learned that they could, or their physical state changed, and then they could. So again, speaking to this misinformation that people with chronic illnesses can't safely get vaccinated. During the questionnaire, we asked a number of yes/no responses to potential reasons why people got vaccinated. The responses here show that increased access was beneficial for many. We see that almost 60% mentioned a closer site opening up as a reason that they got vaccinated, and almost 50% saying that being able to go after hours or on weekends was also a reason that they vaccinated. The bar on the very right shows the responses among just the subset of individuals who were age eligible for the Vuma voucher incentive program, which was individuals over the age of 50 and over. We see that among this group in our sample, 30% said that they got vaccinated because of the Vuma voucher. We asked a series of questions to try and get a sense of whether people were happy to have been vaccinated. Overwhelmingly, the answer is yes. We see that 9 in 10 were happy to be vaccinated. 75% recommended the vaccine to someone else. 84% intended to get their second dose Pfizer or J&J booster. And 80% said that they felt the same or better than they expected to feel. We now turn to look at the findings from the unvaccinated respondents. Interviews were conducted in all provinces, again with the most interviews done in the most populous provinces. Again, almost half the sample resided in a township or informal area. This figure shows the number of respondents by age group and gender. We see a fairly even split, male and female, but we see a very skewed distribution towards the left in terms of age, with a lot more respondents in the 18 to 34-year-old category than in the older age groups. 68% had completed matric and 24% reported having medical aid or health insurance. Both these figures are slightly higher than the national average we see in other national South African surveys. Many in the sample were resource constrained. We see that 1 in 5 lived in a household in which someone went hungry in the past 7 days, and receipt of social grants was also very common, with 57% saying someone in the household received some sort of government social grant. In addition, we see that 54% of our sample lived in a household that earned less than 5,000 Rand per month. Looking at health-related indicators, 1 in 5 reported that they had had COVID, and nearly half lived with someone else in their household who was vaccinated. We found that mental and physical health was quite poor. 22% reported having a chronic condition, which was HIV, a lung condition, heart condition, high blood pressure, or diabetes. And 3 in 10 screened positive for depressive symptoms. One of the most important findings from the survey is that most of the unvaccinated individuals do not plan to get vaccinated. We asked the question that appears at the bottom of the screen regarding the COVID-19 vaccine. Do you plan to get it as soon as possible, wait and see, only get it if it is required, for example, if it is required for school or work, or definitely not get it? We see that 6 in 10 fell towards the most hesitant side of the scale, with 24% reporting they'll only get vaccinated if required, and 36% reporting they will definitely not get the vaccine. Throughout the presentation, try and keep in mind that most of the sample sits in the only if required and definitely not groups. Most are towards the most hesitant side. And throughout the presentation, you'll see that we've used the colors of each of the groups as shown here to when we show data for that specific group in any of the figures or charts. So the distribution of vaccination intentions shows a dramatic shift from the distribution we saw in Survey 1. Looking at the figure on the left, we see that in Survey 1, the majority in orange reported either wait and see or as soon as possible. They were more towards the least hesitant side of the scale. Whereas in Survey 2, we see a lot less orange, and we see a lot more hesitancy in blue. In the figure on the right, for this information, we asked respondents in Survey 1 whether they thought they would be vaccinated by February 2022, which was approximately 2 months after the Survey 1. And then in Survey 2, we asked respondents, will you be vaccinated by May 2022, which was also approximately 2 months. Again, we see a dramatic shift towards more hesitancy. In Survey 1, 46% said they would be vaccinated by February, and 29%, but only 29% in Survey 2 said they would be vaccinated by May 2022. I see some hands being raised. Please do feel free to put questions in the Q&A, and we'll get back to those. Thank you. We also see that vaccine hesitancy has become really entrenched. This table looks at the respondents who were surveyed in both Survey 1 and Survey 2, and they were unvaccinated in both Survey 1 and Survey 2. We've had a look already at the vaccinated respondents, and we've seen what their stated intentions were in Survey 1. Those individuals are not in this table. We looked only at the unvaccinated individuals in the panel. What you see here is in the rows, you see the intentions that were stated in Survey 1, and the figures show the percentage of each of the group for each of the intentions in Survey 1, and where they fell in survey 2. The larger font shows individuals who reported the same intention in both survey 1 and survey 2, and the blue arrows show the general shift in intentions towards more hesitancy in survey 2. So taking an example, looking at the row which starts with the wait and see, for those individuals, we see that the wait and see group in survey 1, 27% of them said wait and see again in survey 2. However, we see that the majority shifted towards being more hesitant. So 29% of those who had said wait and see in survey 1 subsequently said only if required in survey 2, and 24% subsequently said definitely not in survey 2. The 44% for the as soon as possibles shows that less than half remained as soon as possibles, and the others shifted towards being hesitant. Slightly more encouraging is that for the row which is definitely not, we see that about 25% shifted away from being the most hesitant group, away from saying definitely not, and moving slightly to the left. We now move back to looking at the overall unvaccinated respondents. So now we're looking at survey 2 only, and for all unvaccinated individuals in survey 2. What we see is that across all age groups, 6 in 10 do not want to get vaccinated. So the high levels of hesitancy is seen in each of the different age groups. However, what we do see is that among the 18 to 34-year-olds, a lot more of that group said only if required, the column on the left, and the 29% in gray, a lot more young individuals said only if required than any of the other age groups. This provides signal that mandates may be most likely to work among younger groups. This figure also indicates that more intensive longer-term strategies will probably be needed to shift the large degree of hesitancy, especially amongst the older population. We also see that men are more hesitant than women. The blue at the top of the bars shows that 40% of men said definitely not to getting vaccinated, compared to 31% of women. This indicates that interventions tailored by gender may need to be considered. This is potentially especially the case among younger populations. Currently in South Africa, among the 18 to 34-year-old age group, the overall vaccination coverage is 41% among women and 31% among men. That is a really, really large gender gap, and all pointing towards potential interventions tailored by gender. Several of our findings show a really strong association between socioeconomic status and vaccine hesitancy. We see that hesitancy is higher among the more educated. We also see that hesitancy is higher among those with more resources. The figure on the very left shows the percentage reporting living in a formal residential area. We see that individuals who said that they intend to get vaccinated as soon as possible, about 20% lived in a formal residential area, while almost double the number at 40% of the definitely not group lived in formal residential area. And that pattern is seen consistently through our different measures. Of concern, we see that people with a chronic illness are not more inclined to get vaccinated. The figure on the right shows the intentions among those with a chronic condition. We see that 19% in the orange bar reported they want to get vaccinated as soon as possible. Comparing to the left figure, those who did not report having a chronic illness, we see the exact same percentage, 19%, saying that they want to get vaccinated as soon as possible. We also see that vaccine hesitancy is only slightly lower among the those living with chronic conditions, the blue bars, with more than 30% of those with a chronic condition saying that they definitely do not plan to get vaccinated. We also see very low beliefs that the vaccine works, and vaccine efficacy beliefs is associated with vaccine intentions. In this graph, we look at the percentage saying that they do believe that the vaccine will help prevent them from dying from COVID-19. The as soon as possible group, roughly 70% believe the vaccine would be effective. But as soon as we move to the more hesitant groups, fewer than 40% reported that they thought the vaccine would be effective. And to the most hesitant, only around about 10% thought it would be effective. A large number of our measures also were consistent in showing that for many of the unvaccinated respondents, many don't think they need a vaccine. What we see in the first set of bars on the left for the my body is strong enough, if you ignore the as soon as possible group in bright orange, we see that more than 60% of the vaccine hesitant cited that their body is strong enough as a reason that they were not vaccinated. Looking at my God and ancestors will protect me, again, for a second, ignoring the as soon as possible group in dark orange, we see that around about 50% of respondents who are vaccine hesitant said that one of the reasons is that my God or the ancestors will protect me. Now focus on the as soon as possible bars across, which are in the dark orange. And it's quite notable that even among people who want to get vaccinated as soon as possible, there's fairly low perceived vaccine relevance. So almost 50% of the as soon as possible group said that their body is strong enough and they don't need a vaccine. The next three slides paint a story of widespread concern about vaccine safety. The figure on the left, we see the responses to the question about whether a vaccine is safe for the babies of pregnant or breastfeeding women. Taking a look at the definitely not group, we see that 71% said that they don't think the vaccine is safe for the babies of pregnant or breastfeeding women. And across the vaccine hesitant groups, 50% or more reported this concern. Also, striking again, having a look at the as soon as possible bar on the very left, although individuals say they want to get vaccinated as soon as possible, these individuals also have widespread concerns about vaccine safety. Here we see that 33% of the as soon as possibles don't think the vaccine is safe for babies of pregnant or breastfeeding women. On the right, we see perceptions around safety in relation to people living with a chronic condition. The vaccine hesitant groups in the very three most right bars, around about 50 to 66% said no, the vaccine is not safe for those with chronic condition. In survey one of CVACS, many people reported that they thought the vaccine could kill them. So we wanted to probe this a little bit more in survey two. So we said to participants that you may have heard that the vaccine could kill someone. How strongly do you believe that this is true? What we see here is that among the vaccine hesitant, many people believe that the vaccine, many people believe either strongly or little that the vaccine could kill you. In the definitely not group on the bar on the very right, we see that 41% said they believe this a lot, and 26% said a little. Again, drawing your attention to the fact that most respondents who are unvaccinated sit in the only if required and definitely not groups. So most of our respondents are in those two columns. Given that, we see that overall, most respondents believe that the vaccine could kill. So we've seen what respondents thought about the effectiveness of vaccines and what they thought about the safety of vaccines. So we asked a question around the calculation that people might make around weighing up the costs and the benefits. And what we see here is really when push comes to shove, we ask people, do you think that the COVID-19 vaccine is more likely to keep people healthy or more likely to harm them? And we see a pattern which is strikingly associated with vaccine intentions. Among the as soon as possibles, people pick health. They think vaccine is more likely to keep people healthy. Among the definitely nots and the more vaccine hesitant, people pick harm. They think the vaccine is more likely to harm them. It's worth noting that 60% of those in the most hesitant group believe that the vaccine is more likely to harm people than keep them healthy. We also see general mistrust in government information around COVID. The bars show how much people trust information from the government that's been provided around COVID-19 and the vaccine. In the more hesitant groups, we see that only 25% believe the information a little bit, and only 9% believe the information a lot. So 64% or the most hesitant don't believe information at all. Looking at the as soon as possibles on the least hesitant side of the scale, even among those individuals who want to get vaccinated, we see that only 55% say they trust information from the government around COVID. Then we asked individuals sets of yes/no questions around reasons for not having been vaccinated. And from these sets of questions, it was evident that access constraints still remain. So almost 50% of the sample said that one of the reasons they have not been vaccinated is because they do not have time to get vaccinated. That was in the as soon as possible group. The access constraints become a lot less prominent in the more hesitant groups. So both the not having time to get vaccinated and the vaccination site being too far away was much more common among the as soon as possibles as a reason for not being vaccinated as among the definitely nots. I'm now going to hand over to my colleague Linda Kuchler, who is going to walk us through other reasons why people have not been vaccinated. Lindo is a lecturer at the School of Economics at the University of Cape Town, and part of the CVACS team. So, Lindo, over to you, and thank you.
Thanks, Brendan. Hello, everyone. So I will be jumping in and adding to the reasons Brendan has just discussed amongst unvaccinated people as to why they have not been vaccinated. I will be focusing on the main reason they cite across the 4 intention groups for why they're not being vaccinated, have not been vaccinated yet. Next slide, please. So as explained earlier, each phrase, the size corresponds to the frequency in which the response was listed. This slide is in response to the question of what is the single biggest reason that you have not been vaccinated amongst people who indicate as soon as possible. As you can see, the 2 largest are no time and access issues, which encompasses a broad range of limitations, which I will discuss in a moment. The no time group, many people listed a variety of reasons such as family commitments, but work and job related limitations were also quite common. In the general access issues group, people cited reasons like the vaccination site is too far away, or they had physical limitations which prevented them from, for instance, standing in lines. And some were even discouraged by their perception of the lines they would have to stand in, and other reasons were cited, such as not having an identity document in the broad encompassing group of access issues in general. Next slide, please. In terms of the wait and see group, the most commonly cited reason here is I do not need the vaccine. This is a broad category which includes people who say that they're in very good health and so their immune system will naturally protect them. It also includes people who consider themselves as people who follow a healthy lifestyle and adhere to non-pharmaceutical COVID prevention measures, such as wearing masks and social distancing, etc. Though that was the most common main reason cited by the wait and see group. As you can see, there are some health concerns which begin to surface around the general safety of the vaccine, with issues of vaccine kills and harms and side effects beginning to become more prominent in this group than in the other groups. And a similar story arises with issues around rumors and stories and needing more information, both of which were not frequent responses amongst the as soon as possible group. Next slide, please. And moving now on to the if required. Next slide, please. Again, the trend amongst the hesitant around not needing a vaccine is evident. In this group, however, we can see that vaccine efficacy becomes quite prominent as a main reason. In this case, vaccine efficacy represents both the prevention of serious illness and or the prevention of contracting COVID to begin with. What I would like to highlight amongst the only if required group is that the belief that COVID doesn't exist at all now appears as one of the 10 most commonly cited reasons, which was not the case amongst the first 2 groups. I will now move on to the definitely nots. Next slide, please. Again, as the trend continues with the vaccine hesitant amongst the definitely nots, with I don't need a vaccine being cited quite often by respondents as the main reason. Similar reasons are cited around side effects and don't trust the vaccine. But I do want to highlight how in this group, more permanent beliefs around my health is in God's hands or it is against my religion, and the belief that that COVID or the vaccine is a conspiracy begins to surface as one of the main reasons. None of these factors had been mentioned frequently amongst the other groups. Thank you. I will now pass over to our colleague, Alison. Thanks, Brendan.
Thanks very much, Lindo. It's great to see these results. And as always, just a real privilege and honor to be on this team and join this effort. Next slide, please, Brendan. As if you were around for our Survey 1 webinar, you may remember that we embedded at the very end of the survey a brief experiment to evaluate some different messages that might be used for vaccine promotion. And we did that again for Survey 2. Again, at the very end of the survey, you either received no message or you were randomized to hear one of two messages around basically benefits or value propositions for getting vaccinated. I think this is one of the more exciting ways in which we incorporated policy input for the Survey 2 experiment. The value propositions that we tested were directly from NDOH, the Demand Acceleration Task Team that was doing some work on youth-focused campaigns and had identified these value propositions in focus group work. And those value propositions have been informing the K-Ready campaign that you may be seeing. So we pulled with some input from our consultative group, two messages, two value propositions from those that we wanted to test. If you bump to the next slide, Brendan, we can show you exactly what those looked like. So you might hear there are many reasons why a person might decide to get the vaccine now, even if they had previously decided not to. For example, one reason might be so that they can enjoy greater freedoms. So enjoying greater freedoms was the value proposition there. And then the interviewer would ask, do you ever feel that way? And that was mostly just a way for the respondent to engage a little bit cognitively or emotionally with that question. That was the greater freedoms message. On the next slide, you can see the solutions message. So exactly the same prompt. There are many reasons why a person might decide to get the vaccine now, even if they previously decided not to. For example, one reason might be so that they can be part of the solution and help end the pandemic. And then again, asked, do you ever feel that way? In terms of our results, and again, if you were with us for the Survey 1 webinar, you might remember these quite small effects of these messages. We did want to analyze these results separately for 18 to 34-year-olds versus 35 and plus, because these messages came from a youth-focused campaign. You can see on the left that compared to not hearing that message before you're asked, do you think you will have the vaccine, get the vaccine by May, the freedoms message and the solution message each gave about a 3 percentage point bump, pretty small. For the older folks whose overall intention to be vaccinated by May was lower, fewer people in the no message group even said, yes, I'll likely be vaccinated by May. Freedoms didn't do anything, and we got a little bit of a bump from the solution message. So we have a couple takeaways here, and excited to engage with our panelists and with our attendees on this. So one is, this is actually quite in line with other results from around the world on COVID-19 vaccine messaging at this point in the rollout, right? We wouldn't expect to see 10 percentage point bumps or doubling, right, of people's intentions just on hearing a message. And of course, because intentions don't perfectly predict behavior, we might really see these as a ceiling on the kind of results we might expect for actual vaccination behavior. So on the one hand, minimal bumps. On the other hand, messaging interventions are pretty low cost. They can be sort of a scaled, fairly easy, low-cost way to get interventions out. And because of that, we really think it's important to start accumulating really good cost effectiveness analysis, where we know both the cost of sending these interventions out and the investments in vaccine demand creation, and the benefits, financially and health-wise, for getting certain groups, to a higher coverage rate. It may be that even for a 3 percentage point bump in an intention to vaccinate, this message is cost-effective, is potentially more cost-effective than other investments we might be making at this point in the rollout. So lots to think about and dig in there. I'll hand back to Brendan.
Thank you, Alison and Lindo. So in this final section, before we conclude, we take a look at respondents' views about mandates. Respondents were asked how much they support or oppose mandates. Overall, we see really strong opposition to mandates, with those in the more vaccine hesitant group showing the strongest opposition. In the bar on the right, we see that 90% of those who said that they definitely not plan to get vaccinated, 90% opposed or strongly opposed. It's also worth looking at the column on the left for the as soon as possibles. Among the group that do want to get vaccinated, we have 40% who are opposing or are strongly opposing. So we then asked individuals who support or strongly support the vaccine requirements or mandates why they feel this way. We see that overwhelmingly the most common response was that vaccines prevent spread and save lives, and linked to this, that mandates ensure that people get vaccinated. Perhaps the most interesting finding from these responses is the fact that there are appears to be a lot of complicated and mixed emotions around the vaccine mandates. In white at the top, we see other reasons being quite prominent. This captures a range of diverse reasons which are really hard to categorize and code into groups. And then we also see towards the bottom that 8% of the individuals who said they do support mandates then told us that it's an individual's right to decide. So this perhaps represents people who think that, okay, mandates are a good idea, but and they have mixed emotions and concerns. Among those who opposed or strongly opposed vaccine requirements, we see that 1 in 2 individuals cited individuals' right to decide as the reason. And we found that linked to that, around about 5% of respondents directly cited that the president or government said it wouldn't be mandate as the reason they opposed. Then for about 15% of respondents, individuals said that they opposed because vaccines may harm people, that they're not effective, or that people just don't need a vaccine. What we see here is that support for mandates is low, despite many believing that they work. We asked individuals, how well do you think vaccine requirements like these would work in getting people to take the vaccine? And we present the responses to this question for each of the mandate support responses. So for those who say they strongly support mandates, we show the responses to how well they think that mandates will work, for example. And what we see here is that in the strongly support group, the individuals who said they strongly support mandates, we see that 63% said they think they'll work very well and 20% fairly well. But I think more strikingly, if you look at the strongly opposed group of individuals on the bottom of the figure, we see that among these individuals, 40% said that they do think the vaccine mandates would work very well or fairly well. So despite believing that they work, mandate support is low. So, in conclusion, we now return to the key findings and implications with this rich context that we now have. Among the vaccinated individuals, we see that we learn that vaccinated people may be our best vaccine ambassadors. We see that they are happy with the decision to get vaccinated. They recommended the vaccine to others, and that their vaccination experience was generally better or the same as they expected. Vaccinated people also can provide social proof that the vaccine is safe, and help counter many of the concerns we saw among the unvaccinated individuals around safety. We see that the actions of people getting vaccinated influenced people to vaccinate in a couple of ways. They saw other people get vaccinated. In particular, we learned that individuals who live in households where someone else is already vaccinated, those individuals are more likely to subsequently vaccinate themselves. And when people got vaccinated, many learned that the vaccination is actually safe, and that convinced many in the sample to vaccinate. So these factors suggest that programming around social norms could still be leveraged, and it's important to increase awareness about the positive vaccination experiences of others. As we move towards the fifth wave of COVID infections in South Africa, it may help convince some people to get vaccinated if we make the risk salient, as we saw that many in the sample who got vaccinated did so because of the high numbers of COVID cases in the fourth wave, and they personally witnessed or became aware of the negative health consequences of COVID-19. Overwhelmingly, though, we saw that the factor that influenced people to get vaccinated the most was mandates, with work mandates being most commonly cited, followed by other mandates. Among the unvaccinated individuals, we see that the majority do not plan to get vaccinated, and this represents a significant shift in intentions since November, December from our Survey 1 results. Quick wins and demand creation strategies may therefore need to be replaced with longer term strategies, especially among the most hesitant groups. We see that vaccination appears to be a privilege that is being turned down by the privileged, with vaccine hesitancy a lot more common among those with more resources. Increasing vaccine access and messaging is unlikely to work that well in better resourced areas. Among people living with chronic illnesses, it is of concern that we don't see that these individuals have a greater intention to get vaccinated than individuals without a chronic illness, indicating that messaging may need to be tailored to this high-risk population who are vulnerable to the health impacts of COVID-19. Such messaging will potentially work best through channels other than through the government, as we've seen that most in our sample now find the COVID-19 information from government untrustworthy. So other more trusted avenues of delivering messaging and campaigns may need to be considered. Three very wide spread concerns and beliefs all point to the fact that it will be very difficult to convince the unvaccinated sample to get vaccinated. We see that most do not believe they need a vaccine, few think the vaccine works, and most believe that the vaccine will harm people, not keep them healthy. People believe that the vaccine is not safe for people with chronic illnesses, for the babies of breastfeeding or pregnant women, and many believe that the vaccine itself could kill them. Linked to this, when asked why people have not been vaccinated, many reported that they believe their current their current health status or physical state precludes them from being vaccinated because they are living with a chronic illness, they are pregnant or breastfeeding, and they think that it is unsafe for them to get vaccinated. So it's really important to create awareness among this group that they can safely get vaccinated and they're eligible to be vaccinated. As we do this, we need to continue to increase efforts to make sure that when people want to get vaccinated, they can do so as easily and as frictionless as possible. Overall, our results from both the vaccinated sample and the unvaccinated respondents point towards mandates being potentially the most effective strategy remaining in the toolkit. Most believe that mandates are effective, but most oppose them, with the opposition based mainly on individual rights and the belief that the vaccine harms people and is not needed. So mandate strategies need to be designed with sensitivity to likely opposition and careful framing of requirements or mandates will be needed. Government's role may be to support and facilitate NGO and private institutions' mandates or requirements while maintaining government mandates where feasible and effective. There are a great number of individuals whose contributions have been invaluable to the success of CVACS. Many individuals on this call contributed to the crowdsourcing of questions and topics for the surveys. The survey 2 topics were informed by various policy inputs, including topics included on religion, included on value propositions, and included on trust, given the direction we had from policymakers and the crowdsourcing contributions. Ask Africa conducted the fieldwork and all the telephone interviews for both CVACS surveys. It's really incredible how Ask Africa managed to produce such high quality work, surveying as many people as we did in such short timeframes. The quotes on the page show some of the reflections from the Ask Africa team and the interviewers, generally reflecting pride in being part of something which helped us understand more about what's happening in South Africa. So to Ask Africa and the team, thank you for your dedication, high quality and rapid data collection. The survey would not have been possible without our respondents, and we really thank them for their time and sharing their opinions and personal information. Respondents were entered into a lucky draw for participating in CVACS, and those winners were selected this week. The Survey 2 data will be released at the end of the month and will be available through the Data First portal, and you can follow us on Twitter. So it's my great privilege now to introduce our three panelists who are joining us today and who have been central in the country's response to the COVID-19 pandemic. We are joined today by David Harrison, the CEO of the DG Murray Trust, who played a pivotal role for the National Department of Health Demand Acceleration Task Team and Chief Directorate. Also joined by Gugulethu Ngubane, who is the Executive Head of Health Responses for the Solidarity Fund, as well as by Masima Mabunda, who's the Head of Vitality Wellness at Discovery Limited. We asked the panelists to provide reflections on the following questions. What do you see as the greatest outstanding challenges for the COVID-19 vaccine program? What do you see in CVACS that could be leveraged to address these challenges? And what else do we need to know now? So I'm going to turn the slides off, and I welcome the panelists to turn on your videos. Thank you so much for joining. David, I'm going to hand over to you first to hear your reflections.
Thanks very much, Brendan, and good afternoon to everybody. It's great to be here. Apologies, I was about 20 minutes late, so if some of what I said is what you've said, Brendan, forgive me. I mean, firstly, just to once again congratulate the CVACS team and others on this call who have been really helping all of us keep a finger on the pulse of the evolution of this epidemic. The NIDS-CRAM work, the UJ surveys, CVACS and the other surveys that have been done have been so important to help understand, and certainly those of us that have been trying to develop effective interventions have drawn heavily on them. Well done to CVACS for its participative nature, the sort of crowdsourcing of questions. It's really been good to see how that has evolved. I mean, I'm probably not a very credible respondent. You know, I've been heading the Demand Acceleration Task Team for the department for the last 6 months. I've now transitioned back to DGMT, and the team continues. And every night I track the numbers. Every night I enter them in because the department doesn't do it for me. But I enter the numbers in a spreadsheet, and I look at what we've thrown at the problem, whether it's VUMA weekends or the VUMA vaccination or social mobilization or communication strategy. I look at what we've thrown at it, and my goodness, the blips are few. What has resulted in an uptick for a while, and that has been sustained either in the right direction or the wrong direction. If we need to say, let's gauge all of our effect in terms of outcome, what has shown an effect is when the president speaks. We see that it does go up, which is interesting. You know, against the light of the feedback here about lack of trust in government. So there's something going on there about the president's position that maybe positions the president above government. I'm not sure, but that's an interesting finding. I mean, secondly, you know, when SMSs went out for a second dose Pfizer for boosters, we saw an increase. And so again, you know, there is some sort of response to the Department of Health's intervention. The thing that made the biggest difference in the wrong direction, knocked 25% of the value of vaccination stocks off the table overnight, if that's one way of putting it, was the local government election. All of a sudden, we saw it overnight, a massive, I don't know how to explain it. Is it a loss of legitimacy in government, a lot of trust, a loss of trust, and we never really recovered from that. And so I guess just trying to reflect instinctively on what has really driven the numbers. It hasn't been, it hasn't been our communications inputs, important though that is. Remember, we have got people through the door, and maybe if we weren't there, they wouldn't have come through anyway. But it has been the big public sentiment swings, and I think trust and trade-offs in people's lives, some of the big trust issues and the trade-offs in people's lives probably have been the single biggest drivers of the trajectory of the epidemic. Now, this is a great survey. I mean, all of these surveys we know have its limitations. This is telephonic. We know that the constraints there. I think the other big challenge here is when you ask people to ascribe motivation. Why did you do something? Why didn't you do something? What part of the brain responds? It's the part that wants to give you what you want to hear. Often, not the part that's really making the decision. So we need to be cognizant of that. And Brendan, you picked up the fact that there's a strong association between belief and intent, and so that does give us a degree of confidence that these measures don't simply reflect sort of social desirability bias on the one hand for those who say they have gone and got vaccinated, but I do think that it's, let's not forget Blaise Pascal. The heart has its reasons, which reason doesn't know, and we have to just hold that we're getting a cluster of results that probably are not necessarily the truth of why people come or don't get vaccinated. It gives us an idea, and so again, the trends, the changes are most important, and that's why these sort of serial surveys have been so important. Not so much the numbers, but what has changed from time to time. And I think, as Hassan said in one of the chats there, obviously as your pool of those who are unvaccinated becomes harder, they're the ones that haven't gone forward. You would expect a higher rates of vaccine hesitancy, but not to the extent that you have seen in the survey. But that really got me thinking. I mean, the first survey was done in November, second survey now. What has changed fundamentally in that time has been the virus, has been the emergence of Omicron, has been a much milder fourth wave, a less virulence at play here. And so I guess I wonder whether we are framing this correctly. Is this a challenge of increasing vaccine hesitancy, or is it a case of risk perceptions that have changed? And if those risk perceptions have changed, are they wrong or are they right? Maybe we're reflecting a higher degree of realism among the population. 90% of those who are unvaccinated said that they won't get vaccinated because I won't get sick, very sick in the next year. They're right, unless we have a new variant. That is right. They won't. And so I think it's a challenge for us, as we still understand the public health imperative. We still want people to get vaccinated. There is still the risk of escape variants happening. We still have to get to a higher risk groups. Long COVID, we still don't know how it plays out. So we still, there's still a case to be made. But let's be honest, it's not as compelling a case as it was in November last year. And so I don't think the media message that must go out is increasing vaccine hesitancy. I think has there been a shift in relative risk perception, vaccination versus not vaccination, as a consequence of the change in the virus, rather than change first and foremost in a set of beliefs. I mean, so coming to the question of what does all of this mean? Thanks, Brendan. I shall do it. What does this mean? I don't agree with you about mandates. So firstly, I don't think we've got the epidemiological case to make for mandates. I hear what you're saying, that there is an association, but we know that in the last three weeks, or the last 2 weeks since the president made the announcement, we have vaccine mandates in place. We do have workplace vaccination certificate, we have public space vaccination certificate requirements, vaccine passports. I do the numbers every night. We still keep going down. So, and I certainly believe when you're dealing with young people, most of them are unemployed. I can't see how workplace mandates are going to be a game changer. So what do we need to do? Well, first, we've got to keep doing the basics. And we need to do the basics, not necessarily because we're going to get a spike now, but because COVID is with us going forward. And so continuing understanding, continuing engagement with the public so that they truly understand COVID in the context of the rest of their lives is the challenge, and we have to sustain that. And so issues of vaccine safety, issues of addressing fatalism that's wrapped up in religious paper, we need to deal with that. Secondly, we have to focus on those that are most at risk. We've got to be looking at the opportunity for reaching people in clinics, HIV clinics, diabetes clinics, hypertensive clinics. So we have to do that, as you said, because people with comorbidities are at more risk, but they don't realize it. And third, I still think we've got to make it worthwhile to people. If we believe that there's an economic case for this country, from a public policy perspective, we've got to make it economically worthwhile for people locally. And so I'm still very interested to see what the effect will be when network operators come in and provide a gig of free data to people who come forward for vaccination. We've heard that VUMA incentives made some difference, not as much as we want, but maybe if we can truly make this vaccination program real in the context of the trade-offs of young people's lives, we'll get some new gains. Thanks very much, Brendan.
Thank you, David. A lot of incredibly valuable insights and food for thought. I'm going to hand over now to Gugulethu Ngubane to get your reflections, please.
Thank you very much, Brendan, and thank you for the invitation to join this panel. I think extremely great things, which some of them align really with the initial surveys we did in 2021, which David is talking about, because we've been really at the core of this whole campaign and the pandemic, and really the importance of having such findings is that we really do craft our messages to respond to the findings, because we take every comment qualitatively and quantitatively that is presented here very seriously, because those concerns that whether it's a person who has vaccinated or a person who's hesitant and shifted to vaccinate, or a person who does not want to vaccinate, they are real to them. It's a real experience. And it was concerning to see that there is an increasing hesitancy and an increasing gap in terms of intention to action. And really a very higher percentage of people who are very clear that they are not going to vaccinate, especially the privileged. We are seeing it in the numbers. We are sitting at 53,000 daily vaccinations, which is extremely low. What is most concerning, because we are pushing for the vulnerable people, the older age groups and people with comorbidities to vaccinate, to see that there is that hesitancy and them not really being confident that we are sure that they are safe to get the vaccine. That is concerning, and it needs integration of these messages as part of health education, because this is not the only vaccine that we have, right? And so it brings some of the outstanding things really in the whole vaccine program for COVID, because it's been a silo program. And that's what we do when we've got a new pandemic. It becomes a vertical program. We remove it from the rest of the services so that there's focus. And there was an urgency with this, because there's these waves that keep on imposing themselves on us. And so the first thing that I felt was the issue of knowledge. It's not that knowledge is not there. Some of it is conflicting. People do not have distrust only on the government. It's amazing that there's nothing that came out that they have distrust on the scientists themselves. However, I think the gap now that there is this, plethora of knowledge, it's how the knowledge is actually being translated and communicated. There's an article by Bexisa and MRC which talked about empathy in portraying and communicating the evidence. So are we being empathic? Are we meeting people and understanding their realities in terms of comprehending and synthesizing the information? And also then the integration of the messaging on vaccines, understanding that vaccine hesitancy for COVID found vaccine hesitancy in general, right? And then how do we talk about the vaccine efficacy, the importance, the significance of it as being a powerful weapon in public health, in averting and eliminating many pandemics that have been here before. The second one is really about how do we influence the intent, closing that intention action gap. In terms of, we have put several incentives based on previous understanding of what those incentives could do, like what is the pull, what is the push, but what more can we still do? Because we still want to really target that 18 to 34 year age group. And what is coming out from this survey is, the interesting concern that is still existing around people that we are targeting the most, which is that age group and the people living in the metros, which are the most privileged, and also people with comorbidities. And we have a KZN and Gauteng having the highest number of unvaccinated people. So how do we take the messages and the findings from this research to make sure that we are targeting those people? And obviously there will be generalized messages, but you also need localized messages that are really targeting the groups that you want to shift from being hesitant to actually saying that they want to take the vaccine. So maybe let me finish on the individual aspect. The issue of obviously the cost, which speaks to access, which you've already touched on, and convenience, the service hours. The Solidarity Fund with DGMT and many other partners, before SA and everybody really, and NGOs, we've gone to support the mobile outreach services for vaccines. But I know that we can still do more in terms of just extending the hours so that it's more convenient, it's where people are, and it's not just on the weekdays, weekends, public holidays, when people can actually go out and take vaccines. Then when you look at the service provision model that we have right now, so currently vaccines really are not part of a general screening. And people are not really, and people have commented on that issue of why do I not get done a basic screening of just vitals? And, so that this is really part of a health intervention, and it's more like we are chasing the vaccine numbers. So there's that lack of empathy, lack of care that people are talking about. It may have or may not have come out of here. So I really support David in terms of the issue of integration within the chronic care clinics and every other opportunity within the system, but also outside the healthcare system or healthcare facilities, looking at public-private partnerships and utilizing other partners that were already supporting the COVID vaccine, so that the mobile services and services outside the health system can still continue to provide the vaccines. Okay, I'm going to finish just now. And really the issue of competing priorities has been a major issue. Right now we're dealing with floods. Last year, July, there was issue of the KZN riots, and then it was the elections. So how do we work with that? So in terms of leveraging on your findings, I think the access issue, definitely there's still more that we can do there to make vaccines more accessible, ease of access, readiness, convenience, and everything. I think in terms of the incentives, it's still really looking at how do we continue to just really close that gap, which has now become even more wider between intention and action, and also to shift the hesitancy. And I thought that my last point is that it's clear to me that the evolving epidemiology of COVID affects also the uptake of vaccines. And I wondered if there was any difference in, or any comments about the effect of the waves, the lockdown restrictions, and the actual variants, because there's something about Omicron that has just made everybody perceive risk to be extremely low because of the low mortality, because I think it's one variant that came with low mortality compared to the previous 3 variants that we've experienced in this country. Thank you very much.
Thank you so much, Gugu. It's really good to keep us focused on the lived realities that really shape people's decisions around vaccination. Really insightful comments. Thank you. Masima, may I hand over to you, please?
Thank you, Brendan. Let me just start by congratulating the CVACS team. This is a brilliant piece of work. I particularly like that we are continuing to actually tap into local data and local insights to inform the work that we do. So this is excellent. I also very much like the fact that we're starting to see an increase in behavior science principles being applied into the health space. So massive congrats and really good work. So I've structured my reflections in the questions that you've asked, which is what are the challenges, what can we leverage from CVACS, and what else do we need to know? So the first challenge that I've noted is that given what you've presented, how do we think about increasing vaccination rates in the populations that are not yet vaccinated, particularly taking into account what David and Gugu have mentioned around the current context that we find ourselves in and where we are with the pandemic? The second reflection point is the topic of boosters. Currently, when you engage with people, it feels like only the clinicians and those that are actually involved in the vaccine program are clear on the role of boosters and where they fit, but it's not common knowledge. And what I'm picking up is it potentially could be confusing the value of vaccines, equally in those that have been previously vaccinated. So I think the challenge is positioning the booster and the booster narrative in the bigger context of the vaccine program so that people are clear as to where it fits in and it doesn't detract from those that have been vaccinated as ambassadors. An interesting anecdote, what we're starting to see is we are starting to slowly lose the vaccinated as ambassadors as the booster conversation emerges because it's slightly uncoordinated. Those people that used to stand up and say, get vaccinated because I'm unvaccinated, they now have question marks. So for me, that booster conversation is important and we need to control that message and make it land in a way that doesn't detract from the efforts that we've been doing. The third challenge is the case for vaccine in children. We have seen, and I don't know if national data corresponds with what we have seen in our world, penetration rates for vaccine in children is significantly lower than in adults. Even where you'll have a family of adults vaccinated, it's not surprising to find that the kids are not vaccinated. And again, when one looks at the narrative and the messaging of vaccines in kids, and I understand maybe it's a case of competing priorities and etc., that message for kids is not coming out strongly. That message, if risk was the bigger driver for vaccination, I'm not sure that we found that thing that would get families to get their kids vaccinated. So the case for vaccines in kids feels like an open-ended question. And then the fourth challenge is overcoming COVID or pandemic fatigue and vaccine fatigue. I'm increasingly finding that though people may not be opposed, but people are just really fatigued and you struggle to engage and you struggle to move them towards action. Don't quite have a solution for that, but I feel like for me personally, something that I'm keen to unpack, especially as we get into the winter season. I'm keen to solve for it, not even just for COVID vaccine, because the question mark is, are we going to now start to see declining flu vac rates because people are just they're tired of vaccines, they're tired of COVID. So those are the 4 challenges for me that are topical. And how can we leverage CVACS? The first point that I mentioned is mandates. It came out in your survey, and it's basically anyone who studied behavior interventions that work, mandates keep on coming up. How can CVACS help us to better understand mandates, or which aspects of mandate work or not, or which elements in in a mandate actually lead people to vaccinate, so that we can see whether we can leverage some version of mandate, and if not, which elements can we co-opt into a vaccination program to drive that. So I feel like we don't quite understand enough around mandate overall. We just have a one blanket term mandate, but haven't unpacked the underlying verticals that can help us progress vaccination rates. And then the second element, and I think Gugu may have touched on it, is do we need to think differently around how we message? Do we need to have specific messages for cohorts that are deemed to be at greater risk than others based on where we are? If we feel that based on where we are with the pandemic, it's still vaccinated, is worth rather in there and traction there versus prioritizing population? No. So for me, I feel there's still needs clarity for the population on boost. The question is on, do you look at all that passed their primary series of vaccine and have been due for boosters getting messages? Take is not as great as one would have thought, especially for people who were first to get vaccinated. But based on where we are in the pandemic.
Sorry, Mosima, we are losing the connection. The line is quite bad now, so shame. I think we might have lost Mosima altogether as we experience load shedding across South Africa. So hopefully Mosima can join back and we can hear the end of her reflections. But definitely a very sort of complex terrain ahead, thinking about how to navigate the different confusions and the fatigue and other factors that Mosima has been highlighting. While we wait for Mosima to join, see if she can come back, let's move to the Q&A sessions. And Kim and the CVACS team, be great if you could please turn on your videos. And Kim, I'll ask if you could please moderate the Q&A, bringing in any questions that came during the presentation. But also, I was about to say any questions for Alison, but I think Alison has had to drop off. So also bring in any questions for the panelists as well. Thank you.
Of course. Well, the first question that I think would be quite helpful, actually hearing from the discussants in particular, is there was a question asking about how is the findings from CVACS going to be used by organizations in thinking about driving demand activities, and then in collaboration with other research associations. If you could give us some insights into that sort of thinking, not only for CVACS, but I suppose for other studies as well who will be thinking about doing this sort of work. So David or Gugulethu, one of you maybe want to comment?
I can start. I think I made an example on specifically the concerns raised by those who have comorbidities and physical health, and thinking that the vaccine interferes with that. I think though that cohort of people can still be convinced to vaccinate. And if we integrate, because I think as we're moving to the endemic phase of this pandemic, if we integrate COVID vaccination into the screening and within the chronic care clinics and chronic care services, then it becomes a continuous talk. And also, I think also just being honest about side effects, because if we as healthcare workers are dodgy and we are not very clear, and we overpromise, then it brings more hesitancy. So being honest about what side effects are there, but also giving confidence to people that there is a system of active response when a person has a side effect, where to go. There is a call center. They're going to your nearest practitioner, and that the practitioners themselves also know what to do, and they're in agreement with the messaging, because I think we are not exactly united with all our healthcare workers. So sometimes the misinformation comes from there. So I think really it will craft the messaging, but also it will inform the integration processes that are currently taking place to move COVID from being a vertical program to be integrated into the mainstream.
Thank you.
very much.
And we
Go ahead.
did see a number of the vaccinated respondents saying that they got vaccinated because they suddenly realized, or they learned that, hang on a second, their comorbidity doesn't actually preclude them. So I think that's a really good point. David, do you want to come in there as well?
Yeah, just briefly. So, so certainly all of this, all of the input that can be gleaned, is directed through the Risk Communication Community Engagement Committee, and there's still a demand acceleration task team. So we're very much seeking to use, to understand, to bring together all of these pieces of information. Literally on a week-by-week basis, the type of engagement that we then have with communicators for GCIS, for Department of Health across the country, very much shaped by the inputs that come in. And CVACS 1, I think we had presenting to those communicators, so it would be great to have that as well. I think the one area that we haven't really been brave enough, shall I say, to tackle, but we got to do it, is the religious packaging of fatalism. I think we've got to try, because that's particularly a big issue for older 34 to 49-year-olds, where we know that we're struggling to get them over the line. They're still at risk, more than the 18 to 34-year-olds, large numbers of people. So that, I think, is a particular campaign that we need to frame and we need to do. And then I really hope that we can crack one of the constraints. The department has not allowed us to date to engage with people who have, who've come for the first Pfizer, haven't come for the second, who've defaulted there, or haven't come for boosters. We're at a point where that's an interpersonal engagement that needs to happen in communities, but also, we have an incredible national contact center that is a missed opportunity. And so it's a tough one. I can promise you we've been engaged with the department for a long time, but I just think that may well provide us with new impetus if we can start to show the value of one-on-one engagement, and to the point of what can we learn from other, for other elements. And to Gugu's point about integration, imagine if we could get some sense of what the power of approaching people who've defaulted, HIV treatment, hypertensive treatment, and actually have a reference point in real time of what can be done with COVID. I think that might well point to sort of cost-effective managed care going forward. Thanks.
Thank you very much for those inputs. There is a question that was left from earlier in the Q&A that we provided a partial answer to. It was by Daniela Casali, who was asking about, in our study, whether we asked about previous COVID-19 infection amongst those who are unvaccinated. And we did do that in the study. And her follow-up question was, did we find any interesting correlations, as this could have implications for messaging? So Catherine, could you maybe give us some insights into that?
Correlations between basically our previous COVID infections in Survey 1 and then things going forward?
She wasn't specific, so I imagine anything that you might have seen. Yeah.
So this is a really tricky one. You'll have seen that Brendan delivered a lot of information, and we have barely scratched the surface of CVACS Survey 2. He could have gone on for another hour easy. He took pity. But basically, it is I'm just going to present a problem here. The problem is that if we find you again in wave 2 or survey 2, you are a special kind of individual because we had a high rate of attrition. So yes, we developed panel weights, but we really have to be super careful with anything that we can, conclusively say about something we observed in survey 1 compared to something we observed in survey 2. To be very careful, we've got to say that we only look at the panel. And yeah, then again, we've just got to be careful with which kinds of variables were associated with attrition or not. All of that said, we didn't find different rates of COVID. I don't think, others on the team can correct me. We didn't find different rates of COVID in between vaccinated and unvaccinated in survey 2, I think, when we pulled through some data. Yeah, so that's a very qualified answer. Any journalists, please don't quote me.
I think it's important to also remember that our vaccinated sample is quite small. There is only 386 people in that sample. So I think that's very good context. Sorry, Brendan, looks like you want to add something.
And that's a really good point, Kim. And just to point out that the data collection, the fieldwork ended just over 2 weeks ago. So as Catherine has said, we're scratching the surface, and we realize that we will keep scratching the surface unless we really release the data as quickly as possible and get more hands on deck. So we're really pushing to get the data published within this month, so that people can follow up with really great lines of inquiry like that. So thank you.
And then there's a question, I'll leave it open to the panelists if someone wants to jump in with an answer to this one. It's a bit more of a political question. So this is from Mark Orkin in the chat, and he's in the Q&A, and he's saying that the point is well made on the relevance of previous work on the role of trust and authorities in vaccine hesitancy. With vaccination so driven by government, the relationships amongst the trust of the president versus lesser trust of government, variously amongst those who are politically support the ANC or other parties, amongst younger versus older, by race. So a number of different factors is potentially relevant. The starting point on different vaccine hesitancy amongst ANC supporters versus other is relevant, noticed by the HSRC UJ group in January 2021. So obviously in our survey, we didn't look at political affiliation and support of people in the sample, but any thoughts on that by any of the panelists, and something interesting that you did see in the data on anything like this?
Masima has been battling to reconnect, and David, I'm not sure if you have any insights on this, because I also don't see if Gugu's remaining. So are you happy to provide any thoughts on that?
So I actually didn't pick up much from the survey on that, Brendan. So I don't know, maybe a member of your team might be better equipped to speak to that.
So this was something which we haven't had much time again to delve into. I've done a lot of work on cash transfers, and we know there are previous studies that show that people that receive cash transfers, like all our grants, trust the government more. So this is one of the ones that I really want to jump onto. We asked a question this time about, are you receiving a grant, whether it's the SRD or child support grant or older person's grant? So effectively, that's on the table, and I'm very interested to see where we go with that. Yeah. There's been a lot of work to get us to here, but we're not at the second level of analysis, I wouldn't say.
Thank you. I see there is a question by, there's a hand up by Brenda Goldblatt. I'm not sure if you're still there. Could you pop it into the chat for us? And then I'll add it to the list of questions. That would be great. Thank you. In the meantime, there are some other questions in the Q&A. So Ruth Capon is asking about how do these shifts towards cementing vaccine hesitancy compare to global shifts? And a little bit more, the second part of the question is how have other countries tackled it? That second part, I think, unfortunately, Alison wasn't able to join us for the whole webinar. She would have great insights there. But any thoughts on that, Brendan, perhaps from some of the work that you've reviewed and thinking about the study?
I feel that I'm not very well placed to be making a comparison to other countries and vaccine hesitancy at this stage. So if anyone else on the team wants to comment on that, I'm happy, but we haven't done a large comparative analysis yet.
I mean, maybe just a comment here. I mean, I think one of the things that I don't think has been sort of very well done and in terms of international comparison, and maybe it's just my ignorance, but when one's comparing sort of aggregate vaccination coverage levels, and obviously South Africa has a low percentage. I mean, the shape of the population, the demographics of the population are not really brought to the fore enough. And you know, I think as South Africa, we really need to congratulate the Department of Health for achieving. You know, when we set out, we wanted to get 2/3. Remember the herd immunity days? Wanted to get 2/3 of the population over the line, particularly those that are at high risk. And that's pretty much where we are in terms of first dose vaccinations, and creeping up for second dose, for full vaccination as well for people over 50. So I mean, you know, it came too late. If only it had come before the third wave, we could have saved a lot of lives. But so I just think a little bit of sort of distinction between sort of a European population which is aged, and a population like ours, which is a very youthful population. So those are the type of factors that I think need to be considered in comparison.
That's a very good point. Another question, I think, Lindo, you'll be great at answering this one, because I know that you read through all of the strings in our data, or what we call strings, which are the open-ended responses. So Lindo did a lot of work on categorizing those sorts of answers. There's a question from Brenda Goldblatt asking, did any people attribute their decision to vaccinate to campaigns or demand creation activity, except for incentives? Did they have any influence on social norms or reassurance? Or would you say this came from interpersonal experience with peers and families?
Thanks, Kim. So I will actually defer some chunk of that to Brendan, because he was quite active with the vaccinated sample. But I will say that in terms of unvaccinated people, a lot of, as Catherine mentioned earlier, a lot of people said, I have heard, or people say as their reasons, and perhaps even, I guess, more interestingly, a lot of people who were worried around people getting really sick from vaccines or dying said, my brother died from the vaccine, or my brother's sister's aunt died. So I suppose there is some social learning network effect happening there, but of course, and it was quite a common response for why people thought vaccines killed. And even though we didn't ask that question explicitly. And so I think, yeah, there is some kind of social network or norm or information being spread, at least amongst the unvaccinated. But I'll leave Brendan to answer the vaccinated part.
Thanks, Lindo. We did get sort of snippets of insights which touched on the potential impacts of campaigns. A number of individuals mentioned increased access, specifically mentioning transport, help, or sites opening closer. And then in terms of sort of contact or knowledge about people getting vaccinated, a number of individuals did talk about the social pressure, talking about not wanting to be the last member of their household not vaccinated, or that not wanting to be left out was language that people used. indicating that campaigns to spread the awareness that many people were vaccinating were sort of touching some people and influencing decisions. I see we at time, and there are a lot of really fantastic questions that have come in. We would love to continue the conversation, and would love you to email any questions that you have through to us, so we can answer those and then pick up the conversation from there. But as to be respectful of time, I wanted to formally close and say a huge thank you to the CVACS team for all the work that has led to here, and to thank the panelists for their incredible insights and being such a valuable part of this discussion, and for everyone for having joined the webinar. So thank you so much, and please do be in touch.